and Dr. A.K. Das for giving me an opportunity to talk on a continuous glucose monitoring. It's very, very important topic, and in next 15 minutes, I'll be finishing my talk to understand where we have to use the CGM. I have no financial disclosure for making this talk. This is very important statement. Somebody had talked that continuous glucose monitoring have a future because intermittent monitoring is not up to the task. Neither it can avoid the hypoglycemia, nor it can get a target range by using insulin. And at the same time, by doing a multiple times monitoring, you are not able to control the glucose variability too. So CGM is a future, and this has been talked in 2013. And after 10 years, we are feeling that, yes, it is really a future, and probably in another 10 years, we all will be using continuous glucose monitoring. Let me give an example. If I do a SMB, actually it is not normal. Person hypoglycemia too. So you can understand how CGM is more useful to know where person is getting hypo and hyperglycemia. It's like a difference between a photography and videography. You know that with a photograph, you can know the random blood glucose level, but when you do the videography, you will know that how the person is actually moving, where the glucose is going up and down. The similar way, the difference between Holter monitoring or just getting a ECG for a routine physician, just to tell them that how they are different, they're getting continuous glucose monitoring or a random blood glucose monitoring. We know that HbA1c, which we are doing since last 30 years for our patients to know the average glucose, but you may have two different type of patients, one with the same A1C, but you will find if you will do the continuous glucose monitoring on left side, you can find that their sugar variability is not very high, while other side, you will find there is a lot of glucose variability. There is a hypo and hyperglycemia, but still person is achieving HbA1c of 7.8. So whether we have to just see 7.8 A1C and further titration of the patient is to be done on 7.8. On right side, a patient will develop more hypoglycemia, but on the left side with 7.8 with less glycemic variability, probably he is doing well. So there is a rationale for using continuous glucose monitoring in the persons who are not meeting with A1C, have frequent low blood glucose level, they are unaware of low blood sugar level, or those who want to reduce their A1C target without increasing the hypoglycemic events, they are the one who need continuous glucose monitoring. The limitations for currently what available monitoring method is A1C, which is the give you average sugar and does not count for hypoglycemia and hyperglycemia in between, and it does not give you any information as far as glucose variability is concerned. If I talk about the SMBG, it gives you the information of that point of time, and when hypoglycemia there, or the overnight data is impractical. Logbooks are really difficult to interpret too. The continuous glucose monitoring, again in India, we have both available, professional CGM and real-time CGM. Professional CGM is with iPro, with more commonly we are using with Libre Pro, but there is a iPro also of a Medtronic, but real-time we have with Libre, we have with Medtronic, and we have with Dexcom too. The classification can be done with a real-time, which is, as I told you, like Dexcom, intermittently scanned CGM, which is a Libre, which is the person has to do the multiple time flashing, that we also call flash glucose monitoring, then blinded one or a professional CGM, which is like Libre Pro or iPro, and there is an integrated CGM, which is also available in our country when it is integrated along with the insulin pump. So person can see his sugar report in the pump itself only, while the CGM sensor is separately placed, but the sugar monitoring can be done in the pump itself. So there are different type of CGM. Luckily in India, we have all varieties of continuous glucose monitoring which are available. If you see over the time of evolution of continuous glucose monitoring, it started almost in 1970, but in India, we started using more after 2000, but primarily in last 5-6 years, particularly when Libre had come in India with professional one, the uses of continuous glucose monitoring in our country also increased. But all over the world, the Dexcom, Medtronic, and Libre, we are very, very popular. And probably in coming near future, we will be having a continuous glucose monitoring, not for 10 days, 14 days, but it will be months together, or maybe with an eye lens with one company is working, probably it will become become, once you put it, maybe lifelong, you can see your sugar report continuously on your mobile, like you are seeing the temperature of your city or the pulse rate, which you can measure through the app or by different way. There are challenges which we used to use the electronic one, which was having a real challenges because 7 days in 7 different colors, the continuous glucose monitoring reports used to come. So interpretation of that was real difficult. And then this a software had come, that is ambulatory glucose profile. We just put all the 7 days report in such a way that you can see the median of it. You can see that how much time the person is having, another 50% of the time moving in hypo and hyperglycemia, what is the level, and the last 10%, even the this 10% also in a slowly noted form also, which you can see that if it is not causing severe hypoglycemia for 10%, even you can omit that. If occasionally it is going in that way, you can omit it also. So this is what ambulatory glucose profile is, compressing all the data of those 7 days, 10 days, 14 days in a format in such a way that you can see that in a median glucose level and how it is moving up or down. So I mean, it becomes much easier for a clinician to interpret the data. Now the question comes, what's the utility of continuous glucose monitoring? Is it really going to give you the information? In 1983, it was showing that when we have done a DCCT trial with a self-monitoring of blood glucose level, the persons could achieve the A1C from 9 to 7.2, which was the average A1C from 9 to 7.2. The severe hypoglycemia rate was 62 per 100 patient year. This is in DCCT trial in 1983. After 25 years, these patients were put on a continuous glucose monitoring, and this was a JDR of CGM data. After 25 years, what we could see, it is decreased significantly the hypo risk by 20% instead of 62. Yes, the newer insulin analogs also we started using, but still the risk of hypoglycemia is significantly reduced by putting the patients on a continuous glucose monitoring, and that's a scientific evidence which we have. But if you put them on CGM along with pump, probably you are almost omitting the hypoglycemia, and this is a data of a pivotal trial in 2016, with the median A1C they could get from 7.7 to 6.9 without a single episode of a hypoglycemia. So this is the utility of CGM, or you can say the scientific evidence behind the using CGM, that it not only significantly reduce the A1C, but at the same time significantly reduce the risk of hypoglycemia too. Now, do we have other study for that? There is a gold study which is compared with CGM versus SMBG. Is the lower risk of hypoglycemia and better quality of life? There is a one silver study which is talking of beneficial long-term HbA1c control in a patient who have treatment satisfaction with CGM versus SMBG. Again, it had shown a significant improvement in A1C as well as risk of hypoglycemia significantly decreased. And then there is a diamond study which is talking of better glycemic efficacy and safety of CGM versus usual care. These were the type 1 diabetic patients, 158 randomly assigned for self-monitoring for 24 weeks. It had shown in its conclusion that significant reduction in A1C with lesser duration of hypoglycemia, the patients who are on CGM. So real-time CGM is superior to flash glucose monitoring for glucose control in type 1 diabetes. Coridia randomized control trial. This trial had talked about the evidence of grade 1 evidence, which is published in type 1 diabetes, that yes, it is having a grade 1 evidence, particularly in type 1 diabetic patients who are using real-time continuous glucose monitoring. In India, we have published one paper with Unni and Shashank and Jyotidev on consensus statement of using continuous glucose monitoring in type 2 diabetes. And these were the patients who are on oral anti-diabetic agent, which we had also talked that how it can be useful for the patients who are on oral anti-diabetic agents and they are type 2. So we have a lot of data from type 1 from the Western world, but we try to do some data from India also. This is a paper which is published in Journal of Diabetology with Dr. V. Mohan, again with Jyoti, Sunil, Manoj, myself, Rajiv, many more persons for talking of retrospective continuous glucose monitoring, which is Libre Pro, for optimizing the management of type 2 diabetes in India. This one more paper which I published, time in range is a target in type 2 diabetes. This is an urgent need. We need for our type 2 diabetic patients also a time in range. That is been a concept primarily been designed for type 1 diabetes when they are using CGM. But if our type 2 diabetic patients also do CGM, probably time in range will give us more idea about the what is the target. CGM is an additional asset in current pandemic because the patients who are not able to come to the clinic or face-to-face meeting, even distantly, they can also contact with their doctors too. And even in the hospitals, even in hospital, we don't have the data more from the ICU, but we have the data, those who are getting hospitalized and in the room, the real-time continuous glucose monitoring can be done. And even their data can be also transferred to the diabetologist if diabetologist is not coming to see them face-to-face too. So they can be used, even the patients who are distantly, they can be treated and they don't need a face-to-face consultation too. Do we have any guideline which is talking of it? Yes, international consensus is talking use of continuous glucose monitoring. Luckily, I was part of this expert group. It has been endorsed by American Association of Clinical Endocrinology. It has been endorsed as a clinical endocrine as by showing that even in 2020, that immediately after the guideline, which was consensus was released in 2020, they are saying that using CGM whenever it is indicated in assisting patient in reaching glycemic goal. And this is for type 2 diabetes. So they were the first one in 2020 that use of continuous glucose monitoring in type 2 diabetes too. A said, talking very clearly that CGM is being recommended for type 2 diabetes patients in the algorithm in executive summary. This is one more paper which we had published in JAPI, using ambulatory glucose profile for improving monitoring and management for type 2 diabetes, and also one more paper as a consensus guideline for glycemic monitoring in type 1 and type 2 diabetes from India too. And one more paper which has recently been published, how frequently they should do the continuous glucose monitoring, but that's a very important question most of the time asked by the physician, that how frequently they should do the CGM too. And this was endorsed by multiple society across the world, including Diabetes India from India, that using CGM is not only for type 1, but also for type 2 diabetes who are on insulin or who are on multiple daily insulin injection. The frequency should be those patients who are very well controlled, even once in a year is fine. But those who are not very good control, once in a month, relatively controlled once in a 3 months, and relatively well controlled even once in 6 months, a professional CGM or a blinded CGM can be done with this. At this point of time, I can't say that we can replace A1C or SMBG. I will say all three are complementary and essential to each other. A person who is doing CGM also should have A1C as well as the random blood glucose monitoring. Let me give you one example of a patient to whom we have started after seeing the CGM, the GLP-1. This is the patient who was already with 9.5 9 HbA1c and was already on a triple drug with a gliptin, with metformin, and with sulfonylurea. He was very uncontrolled. He had gone with 2 doctors. I just put the patient on CGM and we asked them, instead of gliptin, let us put you on GLP-1. And every alternate day patient sugar was getting down. And we stopped her glimepiride from 4 milligram to 1 milligram, and then it was 0 GLP-1, metformin and SGLT2 combination, and you can see here it is very well controlled. So you can see how continuous glucose monitoring have given us the guideline or guided us to achieve a tight glycemic control without getting hypoglycemia and without using even the insulin, and patient is losing weight, recovering, and you can say almost like a getting reversal with HbA1c of 5.8. The patient is maintaining less than 6. So to summarize my talk, continuous glucose monitoring is assisting us for discovering unknown hyper and hypoglycemia. It also gives us the idea about the glycemic variability, assessing the percentage of time in range and out of range. It gives you the severity also of hypo and hyperglycemia. It gives you actionable information which we get from CGM. It gives impact of behavioral variances. It analyzes glycemic effect of new intervention effectively and efficiently, and it also gives care of diabetes which is getting digitalized. So CGM enhances patient health management, adherence, and confidence of diabetes. With this, I once again thank you very much for all the listeners, and thank you very much